Cool. Okay, guys, thank you for coming. So this is our usual EP conference, roughly every month, and I will present a case, okay, that I found very interesting. Okay, so I will skip the next slide because this next slide was meant for another talk. Okay, so the history. So this is a patient who was born to consanguineous parents back in 2019, end of 2019. In utero, he was diagnosed, there was a tachycardia diagnosis with fetal hydrops, but there was no specific any specifications regarding the tachycardia, whether it's supraventricular or ventricular tachycardia. I don't think the fetal cardiologist was able to tell. Anyways, because of the tachycardia with hydrops, mom was treated with flecainide. Okay, guys. However, patient remained, there was no good response to the flecainide and the hydrops was persistent. So they induced the baby at 33 weeks gestation with a birth weight of 2.9 kilo. However, he was there was anasarca, so the estimated dry weight was around 1.9, which is the 50th percentile for this gestational age. He was non-dysmorphic. There was anasarca, like we said. He was noted to be bradycardic, and there was also the lungs were white. Because of the white lungs and anasarca bradycardia, he was rapidly intubated and then transferred to our center after isoproterenol, and dopamine was initiated. Okay, guys. His initial echo showed hypertrabeculated left ventricle with function of around 43%. Okay. And like maternal anti-ROLA antibodies were negative, and there was no family history of note. Okay. There's like no cardiomyopathy, arrhythmia, sudden death in the family that was positive. And this is just a quick, really quick. This is one of his fetal images. As you can see, there is like a situs. And if you pay attention, you can, let me pause it here just a second. I mean, the ventricle appears to be more rapid than the atria if you pay attention. But anyways, there was definitely tachycardia. And then here, with rapid tachycardia, you could see that the ventricles are barely squeezing and very fast. Okay, so this is his like usual rate, and this is his contraction during tachycardia, where you see there's minimal contractions. Okay, anyways, um, he had when he was born, of course, we did an echo, and as you can see, the function is borderline, but there is definite hypertrabeculation on his LV that was يعني noted. But I don't think it met like echo criteria for LV non-compaction, but definitely abnormal looking myocardium. Okay. Okay. So this is his initial ECG after birth. Okay. What do you guys see on this ECG? Someone please try your best. I know, I'm sorry about the quality of the ECG, by the way. But yes.
2 to 1 heart block.
Okay. Sumaya. 2 to 1 heart block. Okay. So everyone agrees or disagrees?
Yes, it looks like.
Okay.
I
Okay.
agree.
Abbas, agree, disagree? Yaqeen, you guys are with me?
But I have a question.
Yeah.
The P waves, are they inverted? But I
Yeah.
think late rhythm one. So
Yeah,
is that significant?
good question. The P waves are funny, to be honest, on this ECG. Um, so I mean, it's very messy. Lead one, two, and three are very messy. So I agree. You might wonder whether the P waves are like inverted in lead one, which usually suggests you suggest you know is P waves that is originating from the left atrium, but there is so much artifact, and there are the next ECG, the P waves looked normal. So I think either there is lead connection issue, or plus minus the artifacts, okay, that is confusing you. So it's a good observation, Yaqeen. But anyways, besides the P wave axis, do you guys see 2-to-1 conduction? Everyone?
Is it third degree AV block because BP interval are and RR interval are regular?
Yeah, so RR interval is indeed regular. With 2-to-1, do you think RR interval would still be regular, right?
Um,
If you have 2-to-1
yes.
conduction, yeah. So the fact that the RR interval is regular may suggest complete. Also, 2-to-1 it also may suggest 2-to-1 conduction. So the fact that obviously the P to P interval is regular, and the PR interval when the P conducts is regular. Okay, so this P conducts, P blocks, P conducts, P blocks. Okay, so if you have complete AV dissociation, the PR interval would vary each beat. Okay, so this is more 2-to-1 conduction. Furthermore, what you guys, it is difficult to notice here, but what do you guys think of the QT? I mean, the T waves are very flat looking T waves, but the QT is definitely generous, okay? Right? I mean, this is the QT interval that's highlighted, okay? The T wave extends all the way to here roughly, okay? Look at V4, okay? Look at V6. And if you measure the QT is around 577. So there's definitely QT prolongation. There is 2-to-1 conduction. The QRS is wide-ish for a baby. Okay. Um, so, very abnormal ECG. Agree, guys, everyone?
But this T wave, Dr. Muhammad, it's related to the other B, not to the previous beat. Yani you are calculating the next beat B QRS or the interval after the second B. So I don't know it's related to the first one or no.
I don't understand your question. So this is the QT from here to here, okay? What do you mean the
Yeah.
P? It has nothing to do
No,
with the
there is
P.
a P wave in between. يعني ال
Yeah,
P اللي
I don't care about this P, but I know the T ends all the way here. يعني the P wave doesn't extend your T wave. It has nothing to do with it. Is this your question, Sumaya?
yeah. يعني انا قصدي ان هي البي دي another beat. يعني المفروض الكيو اللي هو التي ويف تنتهي قبل البي الثانيه. يعني ده what I understand. يعني ليه extend after the second او اللي هي next B اللي هي non conducted او البلوك.
Yeah, so Sumaya, so this is a P wave. You see my pointer, right? That's a P, QRS, P, T. Okay? فهل T is related to this QRS? Okay?
اوكي.
Understood? Okay.
بس انا قصدي ليه ما نتلتش قبل البي الثانيه. يعني البي الثانيه اتس ديبولار. ده اللي هو بدأنا الاتريال كونتراكشن. انا
Right.
قصدي البيت من البيت اللي قبلها.
I don't understand the question.
لا يعني قصدها انه هي كيو ار اس في إلى تي قبل بدء البي الثانية. وين التي؟ ما مبينة هون التي. انه
So
البي
guys,
كيو ار
look,
اس تي بعدين بتجي البي اللي بعدها.
okay. So again, this is the P, صح? P.
Yes.
Okay?
تمام
QRS, okay? This is
تمام.
the
Okay.
next P that is your sinus, because it's a baby. Remember, the baby sinus rate is roughly what? 120, roughly, let's say, right?
Okay.
So this is
ايه بس هي قصدها انه قبل البي هي الساقطة كيو ار
this
اس
is
قبل البي لازم يكون في تي تبع الكيو ار اس.
yeah. So
هون ايوه هون.
this T is تبع ال QRS, okay? ال P has nothing to do. يعني ال P ما لها علاقة في ال QT interval. P just the sinus rate wants to beat at, let's say, 100 beats per minute, 90 beats per minute, 100 beats per minute. It doesn't care what the QRS is doing, what the QT is doing, what the T wave is doing. Okay, Sumaya? So this P,
Okay.
this is the sinus P rate. The patient wants to be at this specific rate, which is what, yani, this is, I don't know if you want to calculate. What is this? This is roughly, what is it? 480 milliseconds. Yani, roughly the sinus rate for this baby is 125. Okay? So every 125 beats per minute, there's a P. Okay?
Mhm.
The P will fall wherever, يعني it doesn't matter. There is the, يعني the sinus node doesn't care what the QRS is doing, what the T wave is doing. It's just firing,
Depolarization will come.
yeah, depolarizing at 125 beats per minute. Okay. But anyways, so this is P, QRS. P came in before the T wave, before
Okay.
the repolarization of the ventricle ends. So that's why this P did not conduct. And the ventricle is still repolarizing. Okay.
Yeah.
That's why the patient is in 2-to-1 conduction. Then LQT is very long. Then repolarization is very long. Okay. Okay. Anyways, so that's Yaqeen. Back to your question, Yaqeen. So, probably the leads are misplaced here because if you see lead one, the QRS is downgoing, which is more normal for a baby. Okay, Yaqeen? So anyways, the P is up right now. Okay, so this is more typical of a sinus P wave, صح? Okay, yani although the AVF P waves are a little bit tiny and funny looking, but we'll assume this is a sinus P wave for this patient. So what is he doing? This is like immediately, these are ECGs within a couple of minutes from each other. So what do you see on this ECG? It's not that easy, ECG, but it's not very difficult as well.
But are the QRS complexes polymorphic?
Okay.
Yeah.
So yeah, this is
Prolong.
Yaqeen. Who's you talking? Yaqeen?
Yes.
Okay, Yaqeen. Okay. Okay. So you're saying there is multiple QRS morphology, صح? Okay.
Yes.
Okay. What do you think of the first of all, the patient is yeah, like more on the bradycardia side, well, tachycardia side, roughly? What are you thinking? Yani, are you thinking of bradycardia or tachycardia?
Tachycardia?
This is a baby, remember, okay? فيعني there are definitely poses.
Brad.
صح؟ صح؟
Yeah.
Okay. First, يعني he had 2-to-1 conduction initially, like just a second ago. And his heart rate here is not very slow. It's better than the previous ECG, but definitely slowish for a baby who's very sick, who's anosarchic, who is يعني decreased function. You would expect more faster heart rate, صح? فيعني you're thinking of bradycardia pathology, okay? So now, how do you explain the bradycardia? Is it sinus bradycardia or there's a form of heart?
كأنه البي ار انترفال عم تطول شوي شوي
Yeah,
Mobitz.
yeah.
بعدين
So
عم تعمل دروب بيت.
right. So it looks like Mobitz 1, right? So the
Yes.
PP interval is regular, but if you look at the PR interval, they're gradually prolonging. Okay? Okay, and then so PR, longer, 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 and then blocks. Okay? Okay. فيقين, I know you noted that the QT remains very prolonged, by the way. Yeah, then again, QRS. The T waves are very small, flat looking, but definitely generous QT intervals. And then Yaqeen, what you were saying, the QRs are different in morphology. This could be aberrantly conducted P wave, or it could be ventricular ectopy. Difficult to tell, but I'm leaning more towards an aberrantly conducted beat because of the, diseased patient, very sick patient, diseased myocardium, and so forth. Okay. So there are indeed what looks like a Mobitz 1 now, and with sinus rhythm Mobitz 1 with QT prolongation and occasionally aberrantly conducted QRSs. And the baseline QRS for that baby is just unusual. Like it's not that, it is more wider than expected for a baby. Okay. But remember, there is myopathy that we saw on the echo. Okay. Which might explain the QRS widening. Okay, guys. Okay. Makes sense, guys. عباس ساكت عباس يعني انت tell me you're agree disagree.
سامعك يا دكتور محمد، بس انا قافل المايك عشان
Okay. So
دوشه
you
اللي
agree,
حواليا وكده.
Abbas? Makes sense?
اه اجري. اوضح
Okay.
كده يا دكتور محمد بعد الشر.
Okay. Okay. So another ECG, like this is again a couple of minutes afterwards. What do you guys see?
دكتور عندي سؤال.
Yeah.
Some of the waves يعني they're the QRSs فيهم like a delta wave looking.
Yeah. Yeah. But it's delta looking, but not pre-excitation, okay? And it's just diseased myocardium with initial slurred QRS. This is the aberrantly conducted beats, yani, okay? Remember, when you see delta looking more, wave, you wanna also like see a short PR to call it WW, okay? So in this case, يعني this delta looking QRS, the PR is so long, يعني عرفت؟ فيعني it doesn't definitely not pre-excited QRS, okay? Okay, so what do you guys see, Abbas? What do you guys see here? Abbas or anyone?
Complete heart.
The same.
Okay, Sumaya,
No, not complete.
be careful,
Complete.
Sumaya. Why do you say
No,
complete? First of all,
BR interval.
الRR it's not regular. هو الBB is regular. الRR not regular.
yes,
Not regular.
that's not complete. Complete, you usually expect regular or interval, صح?
صح.
Okay, but don't jump into conclusions. So just look at it. Yeah, سمعت the same. دكتورة من معانا دكتورة مين معي؟ ما عرفتك.
مين أنا؟
يا من وين دكتورة؟
أنا من السعودية.
والنعم. Okay. فدكتورة you're saying Mobitz 1 صح؟ You said the same.
Yes.
Okay.
Yes, the same.
Okay. So where is my... Okay. So again, PR gradual prolongation. Okay, and then blocks. Okay. تمام. Again, with aberrantly conducted beats, the T wave and the QT is really difficult to assess because the T waves are just very flat looking. But definitely, we know that the patient had prolonged QT interval based on previous ECG. So probably he still has probably that QT prolongation explains the Mobitz 1 and 2 to 1 conduction that we saw in the past. Okay, guys, makes sense? Okay.
Makes sense.
Okay. Okay, so then he had his tachycardia. This is day 1 of life, okay? And he was born, I don't remember roughly when, but yani this is the next morning, okay? Okay, so remember he was shifted to our side. He was in the ICU. We initially thought he's a patient with bradycardia, with some form of bradycardia. And this is why we did maternal antibodies. We thought maybe congenital bradycardia, like, congenital heart block. But the antibodies were negative. The QT was long, but there was LV myopathy. So I was not sure why the QT was prolonged. Is it congenital long QT or is it cardiomyopathy causing long QT? Okay. Then to my surprise, he did this. Because remember in the fetal echo, they said there's episodes of tachycardia, but I never, I did not know what to do with it. But so he demonstrated his tachycardia at day of life 1. And then during this tachycardia, he became very sick. He was pulseless and CPR was started. Okay. So Abbas or anyone, what do you guys think?
Can we say six sinus syndrome here?
Six,
فيتاك
what did you,
فيتاك
six, okay, دقيقة بس سمعت six sinus syndrome. What do you mean? Six sinus syndrome?
يعني tachycardia and bradycardia.
Yeah, okay.
Tachycardia then bradycardia.
Yeah, but my question is, what type of tachycardia is this now?
VTAC.
Okay, so it's white complex, slightly irregular, white complex, ugly looking QRS for a baby. And the baby, remember the patient was pulseless. And then if you look very carefully, you wonder whether it's AV dissociation, which confirms VT. Obviously, the patient behaved like VT in terms of, if you remember the fetal echo, the QRS looked much faster than the atrial. The ventricle were contracting much faster than the atria. Plus, there's AV dissociation. Plus, being pulseless. This all points, and ugly looking white QRS for a baby. This all points towards VT, that widening of the QRS doesn't look like left bundle or right bundle morphology and so forth. So, definitely VT until proven otherwise. and obviously he was very sick, so we had to defibrillate him right away. Luckily, this happened during the day, so everyone was around, and we immediately defibrillated the patient. Okay, so now it's an interesting case so far, very puzzling to me at the time. So now, just to recap, baby had the heart block, has QT prolongation, has LV cardiomyopathy, like a little bit of trabeculated LV function is not normal, and then had ugly wide complex tachycardia, VT until proven otherwise, right? So now you are me, and remember this is back in 2019, which means I just came from the U from abroad. I was a little bit junior at the time. So what do you guys think? How are you going to treat this patient? Like he's in the ICU. We just defibrillated the baby. Now he's back to his Mobitz 1. Okay? Back being stable. But you obviously have to, you have to now do something else, right? What are you going to do next?
What his rhythm now?
Mobitz 1. Like the previous ECGs. Like we defibrillated back into Mobitz 1. Okay? So what are you going to do now?
Observation.
That's it? Observation? Like,
You will need
would
an
you,
ICD.
I mean, this VT would probably come back, right? He had fetal VT. He had post-fetal VT. You will observe until 1, yani. You have to do something, right?
والفليكنايد دكتور محمد.
He already was on flecainide, or mom was on flecainide, and did not do much, remember? I mean, they gave him I mean, who knows how much flecainide was got into the baby, of course. But, it sounded like flecainide did not do much for the baby. And this is why when they gave flecainide, they waited roughly 2 weeks on flecainide. There was no, the baby remained in VT on and off, on and off, on and off. Hydro did not do much. So they elected to deliver the baby. So flecainide, I don't think it's a good choice. And then
Yeah.
plus,
Mm.
flecainide is a decreased function. Flecainide.
Amiodarone. Can we
and,
add amiodarone for him?
Yeah. So amio obviously is an option, but remember his QT is prolonged, and many people would worry with giving amio to a patient who has a QT prolongation, right? I mean, this is I mean, we eventually gave the baby amio, by the way, which in retrospect, I don't know whether what was a very smart choice. But anyways, amio, just be careful when you give amio to someone with QT prolongation, very prolonged QT. Amio might prolong your QT further and then might be more pro-arrhythmic, right? Okay, so it's a difficult question. Yeah.
Beta blocker, maybe. Beta blocker, and
Yeah, you can do beta
you can
blocker.
think of ICD.
Remember his function is depressed, but you can give beta blockers, of course.
Xylocaine, oral xylocaine will be.
Yeah, so that's what I did. So first of all, I was thinking in my, this is back in 2019, so I was a semi-junior. So I was thinking, does he have primary cardiomyopathy associated with heart block and long QT and subsequent long QT interval? Because sometimes cardiomyopathy, any disease myocardium might result in heart block and long QT interval. And then that cardiomyopathy and long QT interval predisposed to VT. Okay? Or does he have primary long QT syndrome causing functional heart block and then caused VT, and then because of repeated VT, the patient went into cardiomyopathy or decreased function, okay? Or, I was thinking, does the patient, so in my mind, what is the primary disease? Does he have a muscle disease that associated with VT and long QT interval and heart block? Or does he have a primary electrical disease, explains the VT, explains the heart block, and then because there's so much VT, he went into cardiomyopathy. Makes sense, guys? Okay, so you have to know what do you think is the most likely for this baby, okay? So this was this is how I was thinking about the case. But in any case, I started lidocaine, okay? طبعا lidocaine is good for long QT patients. It's good for decreased function patients. It's good for VT. doesn't affect your, should not, with heart block should not matter so much. So lidocaine is a good choice. Remember, when you want to give amio, you said beta blocker. Remember, he has already heart block. And then you want to give flecainide, beta blocker, amio, and someone who had 2-to-1 conduction is not, it might be contraindicated, right, guys? So you have to remember there is heart block issue here. So um, lidocaine might in my mind makes the most sense for this patient, at least temporarily. Okay, so we gave him lidocaine. Okay, he did well. Um, and he was at the time on high inotropic support. He was an epi, norepi, vasopressin. He had high lactates. His anasarca was worsening. So the patient was sick. Okay, but because I know that we want to give some lidocaine is an IV drug, we want to give something oral at some point. I had to pace the patient. Okay, so we did epicardial temporary pacing wires implanted. We also did we drained the peritoneum and we inserted chest tubes and we started pacing him at 100 beats per minute. Okay, guys? So now we don't worry about heart block as much. Now there is pacing. So we paced, we continued lidocaine, we kept pacing, and this is his QR, sorry, this is ECG on while being paced. And again, just like really quick, guys. Obviously, do you think are we, as you can see, we are pacing, these are the pacing spikes, okay, guys? And then there's QRS that follows the pacing spike. And then we're not tracking the P waves because it's single chamber pacing, okay? So it's a VVI temporary pacing system. We are pacing at 100 beats per minute. If you look at the QT seems to be improving, okay? Just eyeballing it. And if I try to measure it as well really quick, it's around 490, okay? Remember, it was 580 roughly at day 1 of life or day 0 of life, okay? So the QT looks like the QT is improving. The patient obviously now heart rate is a little bit better, and we're pacing on lidocaine. We did very well for the next 2 days. I stopped lidocaine because I thought maybe just pacing would treat his VT and would eventually improve the hemodynamics and the NSR and so forth. So, and he's in the ICU, so even if he went into VT, we can shock the patient. So we stopped lidocaine, but he had another VT day 5 of life. Okay, similar VT. He was pulseless, exactly same VT. So we shocked him. Okay, so now since he's being paced, I was more comfortable with starting medications. Obviously, I was confused at the time exactly. I was confused in terms of what is the primary etiology. Is it cardiomyopathy or is it long QT syndrome? Long QT syndrome usually has more torsades VT or polymorphic VT. This one had more monomorphic looking VT. Um, usually with long QT, you have more 2-to-1 conduction rather than Mobitz 1. Here we saw Mobitz 1 as well. Remember, family history was very negative. Genetics were not done yet at the time, of course. He had decreased function, so I was worried giving beta blocker with decreased function. And he was already on inotropes, and now ICU is giving inotropes, and now I want to give beta blocker. Did not make much sense, right? So but this is back in 2019. I elected to start amio, low dose amio, and he's in the hospital, and we kept monitoring, of course. So we started amio, we increased the pacing rate, and eventually, day of life 10, we gave him permanent VVI pacing, pacemaker. Okay. His chest slowly he started to improve. His chest tubes came out. His lungs became clear. He was gradually off inotropes. Edema went away. Day of life 14, he was discharged from the ICU, and then eventually he was, the PD was out day of almost a month afterwards, and then he was discharged soon after a month of age. Okay, on amio, no more VT, and pacing at 130 beats per minute. Okay. His function remained borderline, so he was on ACE inhibitors. This is his function um, upon discharge. I mean, it's not normal, but it's not bad. Of course, it's like around 45%. Okay, the septum, remember this is paced QRS or paced function. So the septum's not moving very nicely. but not too bad of a function. Okay. So sorry, what did I do? Okay, sorry. Okay, questions, guys? Okay, questions? Okay, so this is his QRS, this is his ECG while being paced at 130 beats per minute with permanent device. Again, it's a single chamber system, so the P waves are not being tracked. For those who understand pacing, so the P waves are just randomly coming in, okay? Because it's a single chamber device, okay? طبعا in retrospect, one question would be, should we have done dual chamber device? Remember, the baby was sick. He was anasarchic, there was anasarca, generalized edema, bad lungs, high lactates. He was on high inotrope. Of course, we want to minimize interventions, of course, okay? So the QTC roughly, I mean, is around 480 here. But the T wave just is varying. You see this T wave different than this T wave for whatever reason. Okay, so the T waves are a little bit reposition was a little bit unstable, but the number, the measurement looked improved. Okay, so at 2 months of age, this now, of course, his discharge, he came to clinic. I eventually switched him to beta blockers because I felt more comfortable. The function is improving. And AMU again is not very good choice if we are worried about long QT syndrome. So we wanted to give beta blockers, and then the usual beta blockers is obviously propranolol or nadolol, like the non-selective beta blockers. So it initially was on propranolol, and then later transitioned to nadolol. Okay, and then COVID came by, and genetics were done, but during COVID, there was no genetics that were being done. So it took forever for genetics to come back. But at 15 months of age, genetics came back with mutation in KCNH2, which is a long QT type 2 gene. Okay, and also homozygous. Okay. So because mom and dad were consanguineous, if you remember. So it was homozygous mutation in KCNH2, which is long QT type 2. But the company labeled that mutation as VUS, or uncertain significance. Okay, so the company is just saying there is a mutation in KCNH2 or variation KCNH2, but we're not sure whether this is disease-causing mutation or variation or benign variation. Okay, so now in my mind, so this patient probably has a long QT syndrome that is a little bit atypical because homozygous maybe. So that resulted in VT, and the VT is a little bit unusual, being more monomorphic. And then because of repeated VT, the patient had cardiomyopathy. Okay. طبعا when you treat the VT, you would expect the page function to be normal. But remember, he's being paced, and he was 100% paced, and it's a single chamber device. So the function remained abnormal, maybe because the spacing induced. And this hypertrabecular LV, I don't know how to explain. Okay, does he have something else? This trabeculated LV, I mean, is just a little bit confusing. He also had his device herniated to his pelvis, so we had to reposition the device. Does maxilitine has a role? Yes, it does has a role. Usually for type 3, but also there's evidence that maxilitine. I'm just reading a question from the chat. It also works for type 2 as well. So yes, it does. We don't have maxilitine readily available. We do, but it's just not easily available. Okay. Anyway, but he was doing well on beta blockers. The patient was doing very well on pacing and beta blockers. Okay. So he was an ACE inhibitor because of that minimal, decreased function. Usually with QT patient, the QT, low QT patients, once the repolarization improves with treatment and after beyond the neonatal period, the conduction improves and pacing decreases. Okay, and then hence there is less pacing required, but this patient remained being paced 100% of the times, okay? So his conduction, the repolarization remained abnormal, even a couple of years out from being after birth. Remember, it's homozygous, maybe that's why, okay? Questions, guys, so far? Is it confusing or makes sense? Some people came late, so I'm sure you guys are not able to follow nicely. That's why you have to be on time. But any questions, guys?
السلام
أنا
عليكم
بسأل
دكتور
الدكتور
محمد.
Yes, sorry.
اتفضل.
منال قولي you go.
جزاك الله خيرا. ستوري ظريفة، عارفين الحالة. بس كنت عايزة أسأل حضرتك عملت بيسنج ليها، وكان الاي سي جي بتاعها كويس، ليه بدأنا لها الاندرال بيتا بلوكر، ولا هو كان
Well,
البدء الأول؟
well, remember, because the patient had VT while being paced. So we had to obviously do something. We don't want the patient to be in VT because his VT he dies from VT, like he gets pulseless, okay? So we have to give something to avoid VT plus pacing, okay?
يعني حضرتك البيسنج عشان
And then he has
اللونج
long QT syndrome. Long QT syndrome, you need to give beta blockers. You cannot just pace, يعني.
يعني الاثنين عشان الفيتاك واللونج كيو تي.
Yeah, of course, yeah.
شكرا،
Yes,
جزاك الله
Abbas.
خير.
بالنسبة للنان كومباكشن اللي كنا
Yeah,
سسبكتد في
yeah,
أول ايكو،
yeah.
وعملنا لها MRI أو وصلنا لحاجة،
No.
ولا هي دي
Remember,
يعني؟
we cannot do MRI because there's a pacing system, okay? We cannot do MRI. So
بس
echo-wise,
هي
I mean, you guys should tell me. I mean, you guys, no one is calling it LV. I mean, you just keep calling it LV, trabeculate LV. So I don't know exactly whether it meets criteria or not. I don't think it meets criteria, but definitely funny looking LV, right? You guys agree? Mitwalli, do you agree? LV looks funny, right?
Yes. Yes.
Yeah,
Yes.
LV looks funny, so I don't know how to explain it. I don't know how to explain it, to
Maybe
be honest. I don't know.
it will when he will be older, it will be more clear.
Yeah.
Is it non-compaction, or maybe it was just hypertrabeculation after birth?
Yeah, but she's 4 years old and still it's there, yani. It's not like she's 4 or 5 years old. Anyway,
maybe,
so I mean, as someone who is smarter than me should figure out this LV trabeculation. I cannot figure it out. It's not related to this patient. It's just a confusing, like something, But anyways, good questions. Okay. So just really quick, this is more complex. So that mutation is not present in, so when the company tries to analyze a mutation, it always like if there are the control databases like with normal individual genetic genes, and then if this mutation is not present in normal individuals, so this might mean it might be disease causing. But it has not been reported in the past. So it's a novel, like no one has reported that specific mutation causing disease. And then experimental studies were conflicting. So the company were not very sure whether to call it pathogenic or benign. So it called it VUS. So now the ball is in our, we had to figure out that mutation, whether it's like real mutation or disease causing mutation or not. Okay. But in my mind, I know the QT is very prolonged. So it's probably disease causing. And then we will do further stuff to further confirm that, mutation. Anyways, so going forward, now the baby is 3 years old. She gets flu infection, and then she gets sick. She gets intubated. Of course, they stop the beta blocker in Mubarak Hospital because she's intubated. And then while stopping beta blocker, she does this. Okay. So she does, what is this, guys?
like VF?
Yeah, like torsades. This is more typical of, torsades from long QT, okay? So she gets non-sustained torsades. This is off beta blockers. And then they call me, and then I said, oh, you have to resume beta blockers. If she's intubated, like we have to give IV beta blocker, okay? Anyways, so now we know beta blockers are really important for her, right? So she was doing very well for 3 years. And since once she was off beta blockers, she gets torsades, okay? Anyways, okay. Of course, remember she's sick and febrile, and who knows how her, nutrition and electrolytes and so forth. So all things together induced her arrhythmia again. Okay, after being very well for the roughly 3 years. Anyways, so we resumed Nadolol, and then no further VT or Torsats since we resumed Nadolol. So to date, her function remained borderline. LV remained hypertraviculated. This is her last echo. If I can play it. Okay, it's not playing. Anyways, you can see maybe you can see the trabeculation, right, guys? Okay. Anyways, so that's father ECG. Anything remarkable on the father ECG? Remember, he's heterozygous for the mutation, not homo, hetero. Um, Anything remarkable on the father ECG?
لا مش شايف حاجة
Okay,
significant.
yeah, nothing remarkable. The T waves, Abbas, especially you, because you gave us a lecture about QT.
مم.
I mean, don't you think it's a bifid T wave? The T wave is a little bit funny looking, صح? Knowing this patient might have long QT type 2, and remember the
مم.
T wave looks bifid in long QT type 2, okay? So funny looking T wave, but measures normal, okay? I don't know, my computer is slow. Anyways, 430, okay? So measures 430.
مم.
Okay, otherwise unremarkable. This is mom ECG. Anything? She's also heterozygous for the mutation.
التي ويف فلات
Yeah, no, not flat, bifid.
اللي هي اسف بيفد ام شيب.
Yeah, I don't know why my computer is acting up. Anyways, yeah, T waves are funny, okay? Otherwise, measures normal, okay? But remember, now we know the baby, what does she have? So when we analyze the mom and dad ECG, of course we overread that ECG, or we look more carefully on to the ECGs. Okay, anyways. So now, طبعا questions that I'm asking myself, okay, this patient, does she need ICD or sympathectomy? What's up with this hypertrophic LV? Is it pacing induced cardiomyopathy? Should we upgrade it? Because remember, she's a single chamber pacemaker. Okay. So these are all questions that are a little bit difficult to answer. And but I have to address them at some point. But I will mind you the discussion. But so far the baby is 4 years old roughly, doing very well on Nadolol, paced now down to 100 beat per minute. I should probably come down to 90 gradually and 80 beats per minute. Um, the but obviously the patient when she got sick, she had VT, so she's on the edge, right? So maybe I should be more aggressive. Maybe I should give her, maybe we should do sympathectomy. We don't do it here routinely in Kuwait, especially for babies, so that's an issue. Maybe should we give her an ICD, or should we give her atrial lead, and so forth. So these are all questions that are coming in my mind that I need to seriously discuss before it's too late. Okay. Anyways, so that's the case. Questions before I just give you really 5 minutes to talk about like the mutation, the exact mutation for this patient?
Well, only ICD. ICDs can it be inserted from the beginning, or it is large,
Well,
big?
no, it can, but remember the baby was very sick.
Hmm.
Initially, we did not know what is up with the baby. Initially remember day of life 1, we gave, we paced temporarily, بعدين we eventually, gave the permanent pacemaker, but she was still sick at the time. And then epicardial ICD is not easy because more wires, you have to place the wire posteriorly. It's a bigger surgery. Our surgeons are not doing this routinely, so it might not be done well. So there are complications from epicardial ICD. So this is why we try to avoid it. We do transvenous ICD, of course, fine, but epicardial ICD is not routinely done. And but now she's bigger. We can give a transvenous ICD. She's not very big, but she's roughly probably 15 kilos or so. So we're probably another year or two, she might be, large enough for an transvenous ICD. But before transvenous ICD, نظريا we can do sympathectomy. We can give her atrial lead, maybe with better synchronization. This might because now we're pacing ventricle. If we pace the atria, and hopefully the conduction is 1-to-1, then this might be better for her. But the conduction probably will not be 1-to-1, so that's one thing against upgrading to atria, with an atrial lead. But to be honest, safest thing to do may be an ICD يعني عرفت. بس طبعا I don't think she's above 15 kilos, so she's still smallish for an ICD. Okay. But there's a question. What was the cause of heart block? Because of the QT. So when you have very prolonged QT, yes, there's functional heart block. Okay. Okay. Yes, Munam. Exactly. Okay. Okay. So Mitwalli, I think, she probably needs an ICD at some point. Okay. I'm trying to delay it as much as I can. If let's say we have a very good surgeon that does sympathectomy, probably sympathectomy is the best choice. It's the least invasive for her. We don't have. They are from Saudi Arabia, so Nadari and I can tell them to go to Saudi Arabia. We have a doctor from Saudi Arabia here, and they do sympathectomy more routinely there than here. So this is one option that I probably would suggest to the parents. If they don't want to go there or they don't do sympathectomy, I will probably suggest transvenous ICD. That's my, next, another, that's my probably next step, plus minus maxilitine, oral maxilitine, okay? In addition to the Nadolol, okay? Okay, so really quick, so, long QT syndrome, we talked about long QT syndrome just 3 weeks ago, so I will not, bother you with long QT syndrome so much. There are like roughly 17 types. It's not very rare, okay? And for long QT type 2, it's KCNH2 gene, okay? There are congenital causes and acquired causes. Of course, acquired causes, there are many acquired causes, but this patient did not have an acquired cause. And then for the congenital type, you can diagnose it based on Schwartz score, or if there's a pathogenic mutation, or if the QT interval is above 500, that is unexplained, okay? Or between 480 and 500 with symptoms, okay? So this is a Schwartz score. You can just look it up. Um, um, and like we said, long QT type 2, the T waves are usually bifid looking, okay? And this is exactly what the parents had. Obviously, the baby had a very flat looking T waves, but the parents did have what it appears to be like a flat, typical long QT type 2 T wave, okay? Okay. I don't know why my computer is slow today. Okay, and then there's probably another. Does mother need exercise ECG? Yeah, good question, Abbas. I don't. Yeah, we probably should do ECG for both mom and dad and see whether they would demonstrate abnormal repolarization. Remember, exercise ECG for type 1 is when we do long QT syndrome, type 1 is the long QT type 1 is more, exercise stress would be pathological or would be abnormal for long QT type 1 mostly. Long QT type 2 is not as sensitive. عرفت? We typically do for all long QT, but usually for long QT, especially for long QT type 1. Okay? This patient long QT type 2. So, but technically we should do it. I mean, mom and dad are probably now above 40 and stuff, and mom, I don't think she will get, I don't know whether they are planning to get pregnant and stuff. So I think they are, hopefully they are at a lower risk compared to this baby, of course, being heterozygous, and the QTs are at baseline very like normal QT. Okay. But yeah, we should probably do it at some point. Okay. So we discussed this diagram previously. I just want to go real quick. For long QT syndrome patients in Mayo Clinic, the average QT interval was around 480. Okay. But it was all the way from 360, which is very short, to 760. So the number itself doesn't tells you much because there are definite long QT syndrome patients with the normal QT values at rest at least. Okay, so you have to be careful. Okay, so this is why when you have a family with gene proven long QT syndrome, you have to screen that family for the gene. Okay, not just rely on the ECG. Okay. And I will not discuss this further because we discussed this multiple times. And please, if you don't understand that point, either ask me a question now or look at our last conference and we discussed this in details. Okay. Okay. And then I'll skip this because we're running out of time. But just remember, you have to get good history. Exertional, auditory, postpartum seizures are malignant. Okay, swimming is for type 2, is trigger for type 1, auditory startle for type 2, pregnancy, postpartum, and pregnancy is usually a trigger for type 2. Okay, okay. So there is reduction in the potassium current, outward current, hence the repolarizations gets prolonged in KCNH2 mutation. And okay, so now, unfortunately, when you do genetic testing, very often, especially for long QT type 2, you will get a result back that with the labeling of uncertain significance, okay? So usually you as a physician, you have to decide whether that mutation is disease causing. You upgrade that mutation to pathogenic or downgrade that mutation to benign. So you have to you have to study this patient very well. You have to examine the ECGs, the history, and look at all the any previous reports. You have to look up that mutation very well. Okay. So this is what we did. Okay. So we that mutation is in the poor region of the KCNH2, which is usually more associated with more cardiac, more disease, more sicker patients. So this was one point that this might be for, pathogenic mutation. Plus, I just recently, so this family, this is just in 2023, just a couple of months ago. So we had this patient who presented with syncope, okay? And this is ECG. This is an 8 years old or 10 years old, sorry. 10 years old patient present with syncope. This is ECG. What do you guys see? Really quick.
لونج كيوتي دكتور محمد مع بوليمورفيك كيو ار اس.
Okay, long QT, polymorphic QRS, I know there's very subtle changes in the QRS, صح? This is a digitalized ECG. Sometimes the digitalization شوية changes your QRS, so I don't think it was very changing. But yes, QT is very prolonged, okay? If you measure the QT, I think I measured it, I hope. I don't know what's wrong with my computer today. It's very slow. Okay, so, because there's varying R interval, it's anywhere between 510 and 580. Okay. Okay. So good. So you recognized, and then I did genetic testing, and the exact same mutation, if you remember, this was our case. This was our case. Of my computer is frustrating today. This was our exact mutation in the initial case, and this is the mutation for this case. So the same mutation, right? And then guess what? The family name is the same. Okay. So, but they don't know each other. I asked them, do you know this family? They said no. And so they don't know each other, but the exact same, not, the tribe is the same, okay? Same family name, but they don't know each other. Anyways, but this patient was heterozygous, but QT is prolonged. And then this company, which is a different company, labeled it as likely pathogenic, okay? So that company believed that this mutation is disease causing, versus the other company, it's two different companies, they did not think so, but this company did think so, okay? Anyways. So I was surprised, same family, not previously reported, but same tribe, same mutation. طبعا the initial family, the mom and dad had good normal looking ECGs, but the baby homozygous had a bad ECG. This family, this one was heterozygous with a bad ECG. Okay, so it's a little bit behaving differently. Okay, one was behaving like more autosomal recessive, and this family is behaving more like a autosomal dominant, which is typical. Okay, this is the sister on cascade screen. Again, the T waves are bifid, right? You see, guys, you see? Okay, so this sister also was positive. Okay, you see that, guys? T waves being bifid, right? Very clear, صح؟ صح؟ Answer.
تمام يا دكتور محمد،
Yeah.
واضح.
Yes, clear, Dr. Muhammad.
Yes.
Okay. QT is around 470. Okay. So I did not show you mom and dad ECG, but it was coming from dad. Okay, dad was positive. Okay, it's this family. Okay. Anyways, so I collaborated with a scientist from Australia, Dr. Chai. I hope I'm pronouncing his name right. Okay. He is a scientist who does functional data for, he's interested in KCNH2 gene, okay, for this our gene. So I emailed him. I was like, I have this mutation and it was labeled VUS by one company. Can you help us do functional data? So thankfully, he was very helpful and he did functional analysis or data for that mutation. And then just really quick, so this is our mutation. And then the Z-score of the function, the function of KCNH2, the Z-score was like -6, which just tells you the very badly functioning channel. Okay, so when you have this mutation, the channel doesn't function very well. It is the Z-score being less than -2 is more suggestive of disease-causing mutation. So he was able to at least experimentally demonstrate that that mutation would result in loss of function of the channel. Okay, and we submitted that. We submitted this report, and it's under review, and hopefully it should be accepted soon. And it was a nice collaboration between me and one scientist. Okay, and others, of course. Okay, anyways. So, this confirmed what we believe, that mutation is more pathogenic rather than VUS. Okay. So what's interesting now is that case 1 is behaving more like autosomal recessive. Case 2, same mutation is behaving more like, autosomal dominant for whatever reason. Yani. Okay. Okay. So, questions, guys? Okay. So I
I
will
have
not.
a question, unrelated to the case itself, but it's more about like the genetics of cardiology. Yani, since مثلا these patients, they're from the same tribe, well, I'm pretty sure في other conditions that also pertain to particular tribes. Is it worth creating a database to increase the index of suspicion على certain patients when
Yeah,
they
we
come
are.
in?
Yeah, we're doing this. We already have a database, cardiac genetics database in our country. Like I have a database. Of course, it's a single-handed effort. I'm receiving some help from the genetic center, but I'm all my patients with genetic mutation, I'm including them in that database. But so yeah, so we are trying to do databases. Okay. Yeah. So anyway, so we discussed this in the past. We want to avoid specific drugs for long QT syndrome. Patients should be very well hydrated, compliant with medications. Fish oil is typically good. You want to teach family CPRs. You want to avoid loud noises, specific for type 2, if you can. You want to give beta blockers for all patients. I usually give beta blockers for all patients. Very rarely I skip beta blockers. There are specific experts that might after discussing with the patient, if they believe this patient is a very low risk patient, they might not start any medications, just monitor closely. Okay. But this patient, of course, these patients are very sick and they needed therapy. Usually we want to give non-selective beta blockers such as nadolol and propranolol. I will go quickly here. Okay. And because we discussed this in the past, mexicillin is also good for type 3 and type 2. Okay. Flecainide more for type 3. This is why our patient did not really benefit from flecainide. Sympathectomy is an option, especially if you want to avoid ICD or bridge to the ICD. For example, our patient is young, so we cannot give him any. Technically, it will be very challenging to give him ICD. So she's a good candidate for sympathectomy if we are able to do it طبعا, and I believe we should try to do it for this patient. And eventually ICD is recommended if they failed medical therapy, if they cannot tolerate medical therapy, and so forth. Okay. Um, okay, and then just FYI, atrial pacing, assuming there's one-to-one conduction, atrial pacing is usually also therapeutic, and it usually improves or decreases the cardiac event rates. Okay, so atrial pacing is really good for long QT syndrome patients, and if you can see here, the you know the cardiac events rate when before pacing was here, and with pacing went down really quick, especially for long QT type 2, and was statistically significant. Okay, anyway, so atrial pacing is good in general. Having a steady heart rate all the time is usually good for long QT patients. You don't want variation in heart rates, and preferably atrial pacing if there's good one-to-one conduction. Okay, which our patient probably doesn't have. Okay, and then overall long QT type 2 females with intervals above 500 are at high risk in general. Okay, so whenever you encounter a female long QT type 2 above 500, is usually a high risk patient. Okay. Okay, and then fever, like remember when she had flu B, she was febrile, and it induces arrhythmia, and especially for type 2. So fever is a arrhythmogenic in type 2 especially. So this is why maybe our patient became sick when she had the flu B. Okay. Okay, I think I'm done. Yeah, so I'm done. Questions, guys. Was it confusing, or I know many people came late. I don't know why you guys came late. When you come late, the problem is difficult for you guys to follow. So I hope whoever came late, was it confusing, or did you guys follow? Do you have a quick question? You tell me. Questions, guys?
يا دكتور محمد واضحة.
Was it helpful?